Neurology quiz number 46. What are autoimmune associated seizures? Seizures and epilepsy due to immune etiology represent less than 20% of patients of epilepsy, but early recognition is of critical importance as such patients are responsive to immunotherapy. Many patients with autoimmune associated seizures have acute autoimmune encephalitis, and seizures can stop after resolution of the active phase of encephalitis. Such patients do not satisfy the definition of epilepsy and are labeled as acute symptomatic seizures secondary to autoimmune encephalitis. Many patients with autoimmune encephalitis have persistent seizures after resolution of the encephalitis. Some patients with chronic epilepsy may have findings suggesting an immune etiology. In addition, a chronic immune-mediated disorder like Rasmussen encephalitis can be a cause of epilepsy. Such cases should be labeled as autoimmune-associated epilepsy. Autoimmune encephalitis-associated seizures and epilepsy with antibodies against cell surface antigen includes the following: the LGI1 or Caspr2 receptor, NMDA receptor, GABA-A receptor, GABA-B receptor, the glutamate metabotropic receptor 5, AMPA and pptx. These often have good response to immunotherapy and may require only short-term anti-seizure medication. Autoimmune encephalitis-associated seizures and epilepsy with antibodies against intracellular antigen includes the following: GAD65, ANA1 or HU, and anti-MA. These can have inadequate response to immunotherapy and are more likely to require long-term anti-seizure medication. This chart shows the important clinical features of encephalitis associated with antibodies to cell surface antigens. This chart shows important clinical features of encephalitis associated with antibodies to intracellular antigens. Seronegative autoimmune limbic encephalitis, or SNAIL. Manifestations of limbic encephalitis can occur in the absence of antibodies. In such cases, the diagnosis is made by excluding other secondary causes. It accounts for 10% of the cases of limbic encephalitis and is more common in men in their 60s. GAD65 epilepsy. Anti-GAD65 antibodies are more commonly seen in association with chronic epilepsy than neuronal cell surface antibodies. First noted in association with temporal lobe epilepsy, they have also been found in new-onset epilepsy, drug-resistant epilepsy, and pediatric patients. Anti-GAD65 antibody epilepsy is more common in women in the third decade, and 40% have comorbid autoimmune disease like type 1 diabetes mellitus or thyroid disease. Temporal lobe seizures are more common, as is the occurrence of musical auras and musicogenic seizures. The possibility of an autoimmune mechanism for seizures and epilepsy can be established with the help of scoring systems such as the Antibody Prevalence in Epilepsy and Encephalopathy, or APE2 score. An APE2 score of 4 or more predicts antibody positivity with a sensitivity of 98% and specificity of 84%. The ACEs system is another scoring system. This slide shows the items used in scoring in the APE2 scoring system. It is a 10-item index. Special situations in autoimmune associated epilepsy. New onset refractory status epilepticus, or NORS. This is defined as a refractory status epilepticus without a clear structural, toxic, or metabolic cause in a person who has no active epilepsy diagnosis. Autoimmune encephalitis due to paraneoplastic or direct autoimmunity against neuronal antigens accounts for many of the cases, but up to 50% can be cryptogenic. In cryptogenic cases, once infectious causes are ruled out, immunotherapy is recommended early while investigating for a causative antibody. Many patients remain unresponsive to multiple anesthetic agents and evolve into superrefractory status epilepticus. Mortality rate in adults ranges from 15 to 30%. Most of the survivors eventually develop multi-drug resistant epilepsy on long-term follow-up and have significant cognitive and functional impairment. Febrile infection-related epilepsy syndrome, or FIRES. This is a severe epileptic syndrome affecting previously healthy children 3 to 15 years of age. After a non-specific febrile illness, patients have prolonged refractory or superrefractory status epilepticus. The acute phase can last up to 3 months, followed by a chronic phase with clusters of refractory seizures every 2 to 4 weeks. Seizures are often focal, multifocal, and associated with impairment in memory, cognition, and behavior. The condition is thought to represent an immune/inflammatory mediated epileptic encephalopathy. Anti-seizure medications are often ineffective. Usually general anesthesia with barbiturates is required to stop the seizures. Immune therapy is also often disappointing, but some cases have responded to tocilizumab. This slide shows fatiobrachial dystonic seizure in LGI1 antibody encephalitis with tonic contraction of the lower face and the ipsilateral arm. This slide shows a characteristic EEG finding in anti-NMDA receptor encephalitis. The EEG demonstrates frontally maximal high voltage beta activity superimposed on frontally maximum delta waves consistent with the extreme delta brush pattern. This slide shows MRI of limbic encephalitis with axial FLAIR MRI showing increased signal in medial temporal lobe and hippocampus. Treatment: anti-seizure medications. Control of seizures secondary to autoimmune encephalitis is seldom achieved with seizure medications alone, and immunotherapy is required. There are reports that response rates are better with sodium channel blockers, especially carbamazepine and lacosamide. Long-term anti-seizure medications may be required for persistent seizures or epilepsy after resolution of encephalitis. Immunotherapy. This plays a central role in seizure management, especially acute symptomatic seizures associated with autoimmune encephalitis. Seizure freedom is achieved in 60 to 90% of patients, and median time to achieve seizure freedom after starting immunotherapy is 4 weeks. Immunotherapy also favorably influences cognitive and functional outcome. Acute treatment. First-line treatment is usually a combination of IVIG and solimedrol. Plasma exchange is instituted if there is no response to this regimen. Second-line agents include rituximab and cyclophosphamide. Maintenance therapy. Solimedrol 1 gram every 1 to 2 weeks. IVIG weekly, gradually increasing the interval between doses. Or PO-prednisone daily, decreasing doses after 3 months. Rituximab is repeated every 6 months. Mycophenolate and azathioprine can be used to maintain remission and prevent relapses and facilitate discontinuation of first-line therapies.